Watch Before Surgery series. In this video, you'll learn about lateral interbody fusion and spinal fusions. Join Dr. Abbasi as he takes you through the procedure, discussing key aspects such as procedure length, blood loss, infection risks, and much more.
And you see these two and organized and so on. Is that okay? You can start. Hello, this is Dr. Abbasi. I'm going to describe to you different method that we do spinal surgery. And first of all, what you need to know that when you come to us or any spine surgeon, first there are non-surgical treatment, non-surgery. And we always maximize that first. For many patients, believe it or not, just change in activity, physical therapy, injection can help them not needing any surgery at all. And that is our first priority. If we perform all of that and we fail, then surgery would become an option. And those surgeries, they generally come in two categories. One is decompression. Decompression meaning that, imagine if this is you're laying down, we go and take part of the bone off, sometimes more, sometimes less, to get access. Imagine if this is now your nerves here, and if part of the disc material, like it could be any part of the disc material, if they come and push on the nerves, like imagine you have a ruptured disc and it comes and push on it here on the nerve that's passing through like that. We go and just cut the bone to get access and then remove that, and that's called decompression. Sometimes it requires more, sometimes it requires less kind of bone removal, and that can be done open and minimal invasively. Obviously, we do it mostly minimal invasively, but in open and minimal invasively, the goal is to take the pressure off the nerve. But obviously, this does not stabilize your spine, meaning that if your spine is unstable, or the damage is to a point that as soon as you take it off, another piece come and push on, that sometimes is required additional to decompression to do what we call fusion. So first, many patients are helped with a non-surgical treatment, but some patients need surgery. If they need surgery, so this is surgery, some people can be helped with a decompression alone, and some people do need what we call a fusion. In a fusion, additionally to taking the pressure off, so fusion, what we do, imagine you have taking the disc out, and now it's those discs are practical, the material is out, but the spine between the two bone next to that are unstable, they're hitting each other. That can be painful. We are going to make sure they don't move. We are going to put something inside of the disc and then put screws above and below, and internally with different method, make sure that they stay connected together. So before we had these fusion techniques, sometimes it would take people a lot of time before they could walk. By the time, sometimes up to 6 months, by the time they would walk, they would be able, from the pain standpoint, to walk, the muscle would have atrophied, they wouldn't have any muscle to walk with. So we have come a long way in that regard. So if you need a fusion, certainly we will discuss that in detail with you, your situation. If you need a fusion, this fusion, they come in two different methods. And I'm going to extend this. One method is what I call open old-fashioned way, but practically these are methods that they require a big opening, and they have been developed in 1950s and 1980s. And so the open surgeries still are viable for some surgeries. Like if you have this big bad scoliosis that the angles are such that minimal invasive cannot help you, open surgery is still an option. And obviously this mostly is what we call PLIF. We will give you a document to go read about them, but PLIF stands for posterior lumbar interbody fusion, and TLIF stands for transforaminal lumbar interbody fusion. Now, obviously, this method of fusion has been in place since PLIF since 1950s, and for TLIF since 1980s. These are still viable. There are as well the minimally invasive option, and this border here is not a clear border. many people call one of these process that I'm going to show you minimal invasive. Some people call it open, and in reality, depend on how they do that, it becomes minimal invasive or open, depending how much damage you do to surrounding tissue. This TLIF, in the TLIF operation, let's start with the major operation. In the PLIF and TLIF, obviously here we have a lots of muscles around here and here. In this operation, we literally open it up in the middle, push the muscle all to the side, and by doing that, actually we reduce the vascularization of the bone, and we cut the nerves that go to this muscle. Literally, in a traditional PLIF and TLIF, when you do that, this muscle die, they become scarred. They're not really muscles anymore. If you go over like 6 months even later and you open it up, it's all scar, not muscle anymore. And then you cut this bone. So lots of damage, lots of invasiveness, but still for certain situations, this is a viable option. And then you take the pressure off, and then you put a spacer in the disc base, and then you put the screws and you finish the job. The difference between PLIF and TLIF is that in PLIF you go straight down in PLIF, and in TLIF you go at this angle. So this is PLIF, and this is TLIF. And practically, that gives you ability to go take the pressure off and stabilize this spine from just straight down or a little from the side, but still you have to cut a lot of bone to get there. TLIF is the more recent from 1980s, so still almost 45 years old to standard, but it preserves the muscles, preserve the nerves and help them not to get too much damage. Contrary to PLIF, where you have to push the nerves, everything to the side to get to the disc base. Now, for quite sometimes, we can do as well this TLIF in a MIS fashion. MIS, meaning minimal invasive fashion, where you do the same surgery but through a smaller hole. Now, make no mistake about that. Less muscle cut because you don't go from the midline pushing everything away, but you have to do the same surgery through a smaller hole. Most of the data shows that, unless you have done thousands of minimal invasive TLIF, it takes most of people more time to do MIS TLIF than TLIF, and every minute under anesthesia counts. Our studies show that every additional half an hour under anesthesia adds 17% to the combined risk of the surgery, and that this has been collaborated in lots of studies. So if you are going to do MIS TLIF, you have to do it with a surgeon that is very experienced, because otherwise the surgery is longer, and they have to do the same surgery through a tinier hole. So most of data show that MIS TLIF save blood loss and put the people better back to their job and so on. But overall, the final result, according to many papers, seems to be the same. But data changes. Inform yourself. This data is available. Overall result regarding the blood loss and infection rate is obviously much better with MIS TLIF, but some other complications seems to be the same, and the anesthesia time in a very experienced hand can be better, but sometimes, as a matter of fact, in many cases, it actually takes people more time to do MIS TLIF than TLIF. Inform yourself with your individual surgeon. Now, but practically that MIS TLIF is what we talked about. What you need to know, today is April 21st of 2022. Still, to my best knowledge, more than 70 to 80% of the surgeries are performed this way. We are moving toward MIS, and I'm going to talk to you about the series of surgeries now that, depending on how they are done, they can be considered MIS, but it's a fuzzy kind of border if they are or they are not. Let's talk about first what we call ALIF. In ALIF procedure, patient is laying on the back, so this is back, this is front, and we open up the belly. We put most of the abdominal organ to the side, so this is abdominal cavity. There are two, or actually many major vessels, depending on the levels you are here. We have to literally work around them, push them to the side, to get access to the bone to get the job done. This is usually done with the attending and the help of a vascular surgeon or general surgeon, and it can be a good surgery. But make no mistake, whenever you do any kind of surgery, you put whatever you are going through at risk. So it has been many major vessel injuries reported from this surgery, and even death. Obviously, no surgery comes free of risk, no surgery comes with a guarantee, but more material you go through, more risk you are putting them in the surgery. So in this surgery, you go from the front, open up the belly, put the guts to the side, push the major vessels to the side, get to the access to the disc, take the bad disc out, put a spacer in, and then often, more than not, these days what we do, then we take everything off, we turn you around, and then put you in this position, and then we go and put screws again. Here, if this is the vertebral body, imagine these are two bones. Now we are looking here, we are cutting, looking at the section, cutting here, looking up here, we are looking at the side. Now imagine we take, this is the one bone, back of the bone, front of the bone, we took the bad disc out, and we put that spacer in. And then what we do is we go and put literally screws, specialized screws that they go inside here. We call them pedicle screws, and connect them together to stabilize, make sure that the bone stays together and they can grow together. So in most of OLLIF procedures, once we do the interbody part, we tear everything apart, we turn you over and do this surgery in the back. This part can be done minimal invasive or open. Obviously, again, we do it minimal invasive, and doing it open is as well an option. Doing this and then turning the patient, putting screws in the back, can be a lengthy procedure. So, and again, more time on the anesthesia, more risk associated with the surgery. Now, there is a version of this that instead of going from the front, that we call anterior lumbar interbody fusion, that we go a little from the side. And that is called OLLIF, 1L, and dash ATP. ATP stands for anterior to psoas. And the psoas is literally this muscle right here. This is the psoas muscle, or iliopsoas muscle. And in this surgery, they go between the vessels and the psoas in that line here, in a way trying to avoid going through the vessels and put them hopefully at less risk. This is a recent kind of procedure. The result seems to be similar to OLLIF. You still have to go through the belly, you still have to go, deal with the vessels. And this surgery is done usually OLLIF when you're laying down on your back. This surgery is usually done when you're laying on your side. And the hope is that when you lay on your side, all the organ and so on fall away from with gravity, and it gives you a better approach there. It can be a good surgery. Sometimes the incision can be just 4 to 7 inch, something like that. And it can be considered minimal invasive surgery. And the people who do that, they do call it minimal invasive surgery. But again, it's depending on your level of experience, how efficient you can do that. You can do the same surgery with 4-inch incision or 12 incision. If you need, if your surgeon needs 12-inch incision for that, obviously that is less, I would call it minimal invasively, because you have to again go through a lot of tissue to get the job done. Then, additionally to that, there is another procedure that we call XLIF, or equally some people call it LLIF. XLIF is for extreme lateral lumbar interbody fusion. LLIF is for lateral lumbar interbody fusion, and some people call it DLIF. As a matter of fact, we have a method of that we call MIS DLIF. I will come back to that. In that, patient is laying on the side, and literally we go directly from the side here. That is XLIF or LLIF or MIS DLIF. These are all different, direct lateral interbody fusion, direct because you're going direct lateral, generally you are going through this muscle, which is iliopsoas muscle. Now, a lot of nerves going through this, and the vessels are just next here. So you still have to go through the belly. You still have to put those sort of things in danger sometimes. And there are papers out there ask us about that compare these results together. Okay, you should make an informed consent decision regarding your procedure. This is as well another minimally invasive. And many times, because we go from this side and you're laying on the side, that we still have to turn you around and do that, putting the screws in. There's some new method. There are few people have published at 2022. Ask again if you see this video in 5 years. Ask us about that. There are some methods that the surgeon put you on your belly and perform this surgery while you're laying on the belly. Then you don't have to turn you. That's really safe. As a matter of fact, the method of this surgery that we invented, I have written the first paper about this procedure, is that when you lay on your belly, and we do exactly that. We go about here, we go through this muscle and reach spine. In reality, first we go in this angle and then we drop it. For that reason, we don't really put organs in your belly at risk because your organs are usually like that. In our approach, if they do an X-lift, they let you lay on your side, so this with gravity falls off. In our surgery, you lay already on your belly. So in our approach, we start it this way, but then we drop it so it pushes the organs away. The difference is that doing it in your lateral position, X-lift, is about 1.5 to 2 hours surgery to go, and then we have to turn you and so on. Here, under 1 hour, we have done the job with our method. And again, ask question about that. And there are data available comparing all of this together. We have created a document called the War of Lifts, and explains all of this and dissect that. Make sure you get access to that. So these are all the different minimally invasive ways to deal with the spine. And obviously the last, but definitely not the least, is our OLLIF procedure, which we have developed that. And we have put tremendous amount of intellectual property, training and so on. And I have myself, as of 2022, have published 8 or 9 papers about that. These are all on PubMed and they're available. Then I'm just going to delete some of that so I can show you how OLLIF is performed and what is the difference to other MIS approaches. So what I'm going to do now, I'm going to draw again a patient that is laying on his belly. This is the bone. This is the hole where the nerves are passing through. We have decided that all the conservative therapy has failed and just taking the pressure off is not enough. We are going to take the bad disc out. And in this patient laying down here, we have significant amount of what we call paraspinal muscle, and then we have the iliopsoas muscle. The goal of the way we do OLLIF is exactly avoiding the muscles in the back, but as well avoiding all the abdominal organs, which are literally like that. These are your bowels and all the things that are in your belly. In our approach, we try to avoid all of that by going exactly between the muscles in the back and the muscles and organs in the front. It's a very thin line, but the technology allows us to access that directly. By accessing that, once we access that with what we call a neuroprobe, where we literally put electrodes on your feet, and while we stimulate that at certain level with that probe, and we make sure that if you're close to a nerve, it gives us a signal. And obviously, then your position, once we get access to that, we put a tube in. That tube literally is about 1 centimeter or 10 millimeter. And we use specialized tool to go through that tube and get the content of the bad disc out and then put a spacer, and then you're already laying on your belly. So it wouldn't be a big deal here now to go again minimally invasively through the muscle, yes, through the muscle, but we don't cut the muscle, we don't burn the muscle, we don't destroy the muscle. Then we put screws and then do the finish up the fusion. This is the method that I and many surgeons in the United States perform. And obviously, again, you remember we talked about that probably 70 to 80% of the surgeries still in 2022 are done still open. All the others makes 20. And the reason for that, in my opinion, is that you need a lot more education and training to be. These are the advanced things. This is like driving a car. This is like a car. This is driving an airplane or flying an airplane. And OLLIF is flying a space shuttle. That's how you need a lot more education to do that. That's why most of people do this. Some people do that, and few and the proud do that. Get experience level of your surgeon, ask him question. No professional will be offended if you ask them, how many of this have you done? How many of this have you done? But at the end of the day, some surgeons are going to be good, better at one or another. Like I have done thousands of this. I have done hundreds of anterior approach ALIF. I haven't done any of that, but this and this are more or less very similar in their performance. I have done probably a few dozen of the laterals, but MIS DLIF, which is practical lateral, I have done hundreds of that. And I have done, as of today, I have done about 1,500 of OLLIF procedures, and we have put tremendous amount of information online, offline. We are very, very open about our data, and that because we feel comfortable about that. Another thing that obviously you can look up what have your surgeon put out there about their experience with whatever surgery they have done. In the OLLIF procedure, what you need to know that imagine this is the now we are looking at a person. Imagine the spinal cord goes down and up like that. At each level, a nerve root comes out, and this nerve root, like for example, continues, goes down to your leg, and perform an function for you. In the PLIF procedure, you definitely have to push on the spinal cord and to get access, as well as nerve root, but more or less the entry point for PLIF and TLF is here. You have to push the spinal cord and the nerve here and provide some pressure to get the job done. Both MIS TLF and irregular TLF do the same. In the lateral approach, most of the time you are not putting the nerve root at danger, but this nerve root, they go here through this muscle. You do put those nerve roots not exactly here, but farther down in that muscle at danger. And again, no surgeries without risk. Every surgery will come with a risk profile. And I think it makes sense for you to understand as well that the risk profile is not the surgery itself, but as well the surgeon. And that is something that we have to accept. Every surgeon is a human being, and more experience you have, you get better. And so there is a range of acceptable risk profile with any of these surgeries. So, and this is the TLIF, PLIF, and MIS TLIF put that both the spinal cord and nerve at danger. XLIF put that at danger. In some studies, this has been recorded significantly high, probably on surgeons that they haven't done hundreds and hundreds of that. Now, OLLIF goes about here. So, whereas it has been reported that about 8% to 9% of the time that when you go here, you put even we put a nick in the skin around the nerve, we call it durotomy. After 1,500 cases, we haven't had a single damage to the spinal cord, but we do put the nerves at danger. Now, these numbers regarding what is the risk of nerve injury, this is what is the risk of the vessel injury and so on, this is way beyond the scope of this video. But this risk exists for all these procedures. You should ask your doctors. You should ask about those numbers specifically for your procedure in the hand of your surgeon, because this can be very specifically different. Having said that, in our procedure, by proximity to the nerve root, we do put it at danger, but not the spinal cord. Initially, many of these, in all this procedure, many of these damage, injuries, inflammations are temporarily. Most of them do get better. And I'm not going to recite numbers here because these numbers are changing as a good surgeon have to do. We gather our data and we regularly look at those data and we find the results. As of today, the risk of nerve injury here and with TLIF and OLLIF should be considered very similar. But what's not similar is the amount of the bleeding that goes in these surgeries. Like PLIF and TLIF generally have 10 times more risk than most of the MIS, including OLLIF. And as well, risk of infection that in our OLLIF group, the risk of infection so far has been 1/30th or 1/20th of the open surgery. Infections can be sometimes a very heavy kind of complications. As well, the time under anesthesia matters a lot. So far, no data has been provided that shows any of these other surgeries come even close to compete with OLLIF and the time under anesthesia. And it's not like that we speed up the surgery or we hurry it. It's just a different kind of surgery that makes it longer or shorter. The way I tell my patient is that, you get in 1 hour to Chicago from Minneapolis with a plane and you get there 6 hours. The airplane is not really rushing it. It's just the nature of airplane is that is the natural kind of performance of airplane that makes it faster, not because the pilot is rushing it. Okay, so we did a study not long ago and we compared all these studies in all these papers together. And in that paper, we put a chart in that explains the paper very well. If you want to read that paper, you just have to Google it because I publish all my papers as such that everybody can look at that, contrary to some papers that, or some people that publish their papers that you have to pay a subscription or it's just available to selected people. My paper are available to everybody, and I truly believe if it is your health, with some consideration, you can understand that. I know that most of people are scared of these papers because there are too much lingo go into that and so on. But we have tried to write our paper that they are understandable, at least at certain level, to everybody. In that paper, we took all the patients from one hospital, about 388 patients, and we put them in 3 categories. And then we had the BMI. If you don't know, BMI is body mass index, about how big you are as a person. And probably I'm BMI 27. Somebody is very, very big is probably BMI 40 or above. But most of people are usually between BMI 25 and 35, most of the people that come to us. So let's say BMI 20, 30, 40, and so on. We put the people that says how big a person is. Bigger patient have longer surgery time, makes sense to have more complication because you have to work more for the tissue, usually for open surgeries. And in that paper that we published, we put here time of the surgery, time. And we saw in our paper that the time under anesthesia correlates with all the other outcome measures, like how long patient stays in the hospital, what complication do they have, and risk of infection and so on, all correlates with that. So we just took that to make it easy for you to understand. We looked at everything, but we made this chart as such that people who are not necessarily surgeon as well can understand that. So, and then obviously each patient, there are 7 surgeons in this study, including me, and these patients are all over the place. It's like one surgeon did a surgery, open surgery on a BMI of 35, and that patient was here. Then another surgeon did a surgery on a BMI of 20, with a different method. That patient was here, and then we put all of them, and then you can create a chart out of that. We call that the comparison chart of and when you do all of that, we saw that for open old-fashioned TLIF, obviously you start somewhere, and then when you go higher BMI, the time of the surgery goes higher, to a point that when you're at the BMI of 40, most of our societies recommend not to perform surgery, because surgery becomes so long, the dangers and the risk become so high that the risk versus benefit might not be in your favor. Having said that, we as well compared MIS TLIF, and in this study there were 5 surgeons in that group. There was 1 surgeon in the MIS TLIF group, and that surgeon is a very good surgeon. It has done thousands of MIS TLIF, and in that hand of that surgeon, this chart went like this. At BMI of 37, he needed more time than open surgery, and that makes sense because he has to do bigger surgery through had to do a surgery through a bigger, larger, deeper hole. But he had some advantage in the lower BMI. But you have to know, for this curve to move down, you have to have done hundreds of this surgery, because most of people who start this procedure, their curves start up here, but with experience, the curve moves down here. Now, in that study as well, we compared our OLLIF procedure. You remember driving a car, flying an airplane, flying a space shuttle. You need a lot of experience there, but most of our surgeons, they accumulate those experience in a very controlled way. In our surgery, our curve was like that. It didn't make if you do the surgery in BMI of 20 and 40. Not only that, we were half of the time of the MIS TLIF and about 3 times faster than open TLIF, but we could keep that edge, especially in this higher BMI. The difference was tremendous. Again, this data, my data, our data are all available, and you could make a picture of that for yourself before you decide. I know this has been a very short video to bring such a complex matter to your attention, and there are significant amount of publications out there, and we can talk about it in person, and we should talk about it in person, and give you the data that are more specific to your situation. I hope this has been helpful, and please come back and get yourself educated. In 2022, with all the social media, with all the internet and so on, I think there are so many ways of educating yourself. Nobody should go to any surgery without being completely educated. And as usual, always get a second opinion. This is our policy, to encourage strongly all of our patients to get second opinion. Not everybody is good at all these procedures, but by talking to few people who are good at few kind of procedures, you get a good picture of what suits best your situation. Thank you.